Right. So we are going to take two last questions before we have you speak a little bit about reinfection. So a lot of questions coming in about vaccines as such. So to just sum up all the questions that are flowing in, do you think that considering the coronavirus and the genome, there is the possibility of getting an actively working vaccine? And two, what do you think is the impact of mutation on vaccine? We do have some evidence coming in from some data coming in from Australia and UK that really the mutations and the new strain does not affect a vaccine response. But what is your opinion, sir?
Yeah, so a vaccine which can elicit a B cell response is very likely. That's what you have seen. Uh, but what we really do not understand is how how long lasting would be this immune response, or rather how good is going to be this immune response, because you'll always need to weigh in the fact that the serious cases of COVID could also arise from uh, uh, a larger than required antibody detection, and then therefore there is a balance that needs to be kept between the protective immune response and uh, the harm that is created by the antibodies. So I think we should really wait till the phase 3 of the vaccine trials are complete to really understand uh, whether we are going to get a safe as well as efficacious vaccine yet. At this moment, it is still, I believe, in the phase 2, early phase 3, at least for some vaccines. Uh, and I think only the time can really tell us whether we are going to have a safe and efficacious vaccine.
But I mean, just highlighting, I mean, from whatever information we have available and understanding about the genome, we believe that mutations should probably not impact the development of vaccine.
Yeah, so most of the early vaccines have also been built on the concept that there are spike mutations, the spike protein antibodies, which are neutralizing in effect. And then, therefore, uh, since the focus is on the spike protein per se, and a larger proportion of the population today is infected with the A2A clade, which has a D614 mutation, it is therefore a good thing that a larger proportion of the population has a unique variant and a unique kind of a spike protein uh, against which the vaccines have been built. Yeah, but having said that, you need to also keep in mind that there is also evidence of genetic mutations which can now evade neutralizing antibody response. They're at this moment extremely rare occurrences in the population, but of course, as vaccines become what you call widely available and widely immunized, you would see these virus mutants emerge out, because of course viruses are also going to survive, and the fittest would of course survive. So a virus which can actually evade neutralizing antibody response will of course try to emerge at all points in time, and then therefore we need to keep that in mind.
Right. Thank you. Thank you so much, sir. So the last segment, if you can just tell us about the much recent paper which was published about reinfection, which you and your team have published about reinfection in the Indian scenario.
Yeah, so um, reinfections essentially mean that an individual had an infection or an initial infection of SARS-CoV-2, tested positive, typically by nucleic acid testing or RT-PCR, followed by a period of convalescence where you expect the individual to have developed antibodies, and then followed by a fresh new infection at a later point in time. Now, the problem with this entire concept is that there have been health seeking behavior, and health seeking behavior is essentially when you have a symptom, and then therefore only if you have a symptom at both episodes you seek healthcare facilities, you seek testing, and then therefore you are likely to test positive. Now there are multiple scenarios where you otherwise could identify asymptomatic individuals, and it is very well understood that uh, people could be absolutely asymptomatic with SARS-CoV-2 infection. And then therefore the question that we try to ask is that if we look at the healthcare surveillance system, and this is a hospital which we have been working very closely from the early epidemic, and where they have a healthcare surveillance system in place where all clinicians and healthcare workers directly or indirectly in contact with the COVID duties are put on surveillance on RT-PCR every week. Now, in this surveillance, we got hold of two individuals, two healthcare workers, who had asymptomatic infections in both episodes, and they were caught in the system because it was a surveillance system. And so therefore we describe these two infections, and since the samples were also archived, you could sequence these two viruses from the two episodes to understand whether they were the same virus which got reactivated, or they're completely two different viruses which infected these individuals. And from the virus sequencing, what we understand is that there are two different viruses which infected these two individuals at two different time points. Now, there are many implications to this. The first implication is that, of course, the first infection of asymptomatic infection and asymptomatic infectivity to others is very well documented. I mean, there's nothing new about it. But the point that we are trying to really see here is that while you could have an asymptomatic second infection, and as we also show in the paper, is that the CT values of the second infection was actually much lower. That means that they had a much higher viral load in the second infection, and then therefore they're also likely to transmit it to the rest of the individuals. But there are 2 points I need to make here and drive these 2 points here. One is that, one, you need to create a surveillance system, at least in high risk groups like healthcare workers, to be able to understand whether they are infected in the first place or not. Because healthcare workers are, one, at a very high risk of getting the infection in the first place, because they are the people who see patients with COVID. And second, they could be asymptomatic, which is very well documented. And the asymptomatic individuals could now transmit it to other patients, of course, which is very dangerous, or their families, which is also equally dangerous. So at least healthcare workers or people at high risk need to be put on surveillance so that they don't become the super spreaders who transmit this infection to the people around them. Second, the point I need to make is that reinfections at this point in time are extremely rare. At least on documents, they're extremely rare because, one, to prove a reinfection, you need to have 2 samples from both the infections, which is very unlikely because nobody stores the samples, or the testing that is done typically doesn't require the RNA to be isolated. For example, if you do an antigen testing, you would not be able to isolate the RNA from, even if you have archived it, from the original test. So then therefore proving reinfections is extremely rare. Second, proving asymptomatic reinfections are also going to be extremely rare because there are very few places which do regular surveillance. So the idea of putting out this paper is to also enlighten a lot of clinicians and policymakers on the need for, one, surveillance, and the second, need to actively seek out information and evidence on individuals who have reinfections, because globally there are only around 23 or 24 cases of reinfections which are proven from a few millions of cases that got infected. But having said that, we think that asymptomatic reinfections, at least in high risk groups, could be a much discounted entity or much understated entity because nobody really does testing for individuals at high risk.
Right. So, which just brings me to this point here that we have seen a varying spectrum of reinfection, like you said. So, for example, in Hong Kong, where in China, for example, where one of the first cases of reinfection was documented, we saw that the second one was completely asymptomatic. Whereas the same thing when we talk about Nevada in USA, the second one was more severe. And even in the paper that you and your collaborators have written, the second one was more symptomatic than the first time. So is there anything in terms of the genomics by which we are able to predict whether the second reinfection is going to be more severe than the other? Or again, has it got to do with the strain which is infecting the person?
Yeah, so whether the person is symptomatic or non-symptomatic is probably, and this is my gut feeling, probably from the 23 odd cases reported, not related to the virus genome per se, because there's nothing systematically found in individuals who were symptomatic or versus for people who are asymptomatic. The Hong Kong case, the second infection was identified on surveillance because he was asymptomatic. And asymptomatic infections can only be identified on surveillance. And surveillance, of course, as you would also know, is a rare entity. Very few places do surveillance without people having to report that they have a symptom. There, apart from our paper of 2 healthcare workers, there is also another paper of 4 healthcare workers out of Mumbai, which came out of a collaborating lab in IGIB, where the second infection has been more symptomatic compared to the initial infection. So at this moment, looking at the 23, 24 odd cases of reinfections and their genomic variations, doesn't seem that there are systematic kind of variations which cause symptoms and variations that don't cause symptoms. Probably it is a factor of the immune response and what is the kind of immune response that is elicited by this infection.
So when we are talking of all this reinfection, and we touched upon this a little previously, the talk will again come to herd immunity. So understanding the genomics and immunology of COVID, sir, where do you stand on the debate of herd immunity, or the opinion of is herd immunity an achievable target without vaccines?
Yeah, so very unlikely you will achieve herd immunity without vaccines, and probably that's a dangerous proposition because in the process of attaining herd immunity, you end up losing a large number of people uh, for for reasons unwarranted, right? You would not want to kill people to achieve herd immunity, and that's really as a public health strategy, probably a very bad strategy. Uh, without opening up everything, and for example, in a process of uh, letting everybody get infected to achieve herd immunity, probably is a very bad idea. Uh, and even if we achieve a sort of herd immunity, which of course varied projections suggest 30% to 60% of individuals to be infected, there is still no proof that the immunity is going to be long lasting, right? And that's what you need to always keep in mind, that for no other coronaviruses, we have a permanent immune response. So that means that even if you have 60% of the people infected and elicit a B cell response with antibodies, neutralizing antibodies, there's no proof that it is going to be long lasting enough to carry on. And that's essentially where we badly need a vaccine, a very safe and effective vaccine, to be able to reach that kind of a number without having to lose precious lives in the process.
So to understand, reinfections is something that can only be conclusively proved if you have gene sequencing showing 2 different strains or 2 different clades of the virus, and just by having a RT-PCR test being positive for the second time will not conclusively prove it's a reinfection.
Yes, that is because there are 2 close differentials in reinfection. The first differential obviously could be a reactivation of the virus. That means you have a virus that got infected and then the body somehow sort of contained the infection. But at any point of time, the virus could reactivate or could persist in the system to be tested positive at a later point in time, right? And reactivation of virus is probably a much reactivation, or the other case is what we call as long COVID, or a persistence of COVID infection and symptoms is something that is much more common than reinfection, right? So reinfection essentially means that you have a virus, the body would elicit an immune response for sure, or in some cases it might not, or the response is short lasting, that the immune system waned off, that you're now predisposed to another infection. So reinfection theoretically, in my point of view, there's no evidence to support that though, is probably a case of immunodeficiency, right? Because most people, when infected, elicits adequate immune response to give them protection for a fairly quite large time. For other coronaviruses, this could be anything from around 90 days to a year, right? So you expect to have something around that time of a uh, of an immune phase. Um, Now, reinfection between that time, so for example, in these cases, these are around 90 to 100 years of time. That means that these individuals could not elicit an immune response to the second infection in an effective way to be able to contain it. And in my opinion, then therefore they should have something very, very tricky about their immune system, that they lose their memory of the response. Reactivation or the long COVID is much more uh, relevant, and probably much more frequent. We have actually another paper coming up on one such case of reactivation, especially in patients who are on immunosuppressive treatment. And I'm sure you, being an oncologist, you would appreciate this, that we practically use immunosuppression left, right, and center in many of the cases of oncology. And then therefore these individuals could be absolutely asymptomatic, could be tested only on routine surveillance, and then therefore they could activate the virus after a course of, for example, chemotherapy. And that's probably going to be much more frequent entities, though there are very few reports of them yet.
But perhaps one sort of counter view, which is even coming from sort of other people, is that maybe those who are immunodeficient, either be it oncology patients or patients with HIV, are, you probably do not get to see the cytokine storm syndrome or the inflammatory syndrome. But and that is why we are probably seeing them that they are recovering well. But like you rightly said, maybe because of their immunodeficiency state, they may be at a chance of reactivation because of the immunodeficiency state, or even reinfection again. But perhaps the inflammatory storm or the cytokine storm might not happen in them.
You're absolutely right. There have been a number of preprints now available, including one put together by one of my students. Um, and the idea has been that B cell response is probably not as crucial uh, in sort of developing the symptoms, because people with B cell deficiency can still handle the virus and probably remain asymptomatic, compared to people who have T cell deficiency, for whom the virus infection could actually become lethal.